And on behalf of Essity, we would love to thank Wounds Canada for allowing us another opportunity for a symposia. And it's an honor to be here annually and have such a wonderful event live. Thank you. The title of our presentation today is That's a Wrap on Chronic Wounds, Using an Advanced Non-Cytotoxic Wound Therapy Approach to Heal Venous Leg Ulcers with Compression. Today, I have the privilege of introducing to you two amazing guest speakers for us, Dr. Michael Stacey and Amanda Loney. But before we clap them on stage, just a few housekeeping things to address. There will be some poll questions at the beginning of this presentation. So during this, if you'd like to use the Wounds Canada app to participate in those poll questions, please do so. And for the Q&A session after the presentation, for the live audience, there will be microphones being passed around the room. And for anyone attending virtually, please use the Zoom chat to address any questions towards Amanda Loney and Dr. Michael Stacey. And without further ado, please give me a warm welcome. Please help me give a warm welcome to Dr. Stacey and Amanda Loney. Thank you.
Good afternoon. Thanks, guys, for showing up. I know it's a beautiful day out there, so I appreciate you attending. So first couple poll questions here. How many years have you been practicing in wound care? Let's see how long you guys have been out there. Okay, so we got a pretty good mix. We got some newbies for sure, which is great. And we definitely have some seniors. Okay, so let's go, next slide. How comfortable are you implementing the most up-to-date best practices for treating venous leg ulcers? Are you very comfortable, somewhat comfortable, not very comfortable, and not very comfortable at all, and that's why you're here? Again, we got a mix. We got a lot of somewhat comfortable. So hopefully after this, we'll see some more very comfortable. So in your clinical practice, what is the most challenging aspects of treating venous leg ulcers? Patient intolerance for advanced wound therapies, ineffective wound bed prep, so exudate management, more than one of the above. So when we're talking about, patient intolerance, are they not wearing compression? Are they not tolerating your dressings? So a lot of patient intolerance for advanced wound therapies, and then we have more than one of the above, so a combination of things. So here's our conflicts of interest, and nothing too exciting there. So today we will walk through the Canadian Consensus Statement on the management of venous leg ulcers. We'll apply the principles of Canadian Consensus Statement on the management of VLUs with Essity's advanced wound care portfolio, and discuss how relevant findings apply in real-world situations. And we'll welcome Dr. Michael Stacey.
Thanks, Amanda. Thanks very much for that introduction and sort of letting us understand who the audience is. That's very helpful. So what I'm going to talk about at the beginning of this session is just give you a brief outline of the Canadian Consensus Statement on the management of venous leg ulcers. So this is an initiative that we started earlier in the year and completed it in the middle of the year. And so it's in the process of getting published, and you can access it free of charge from a website. The details will be at the end of the talk. So really the objectives of wanting to do this were several-fold. One was to provide a practical, up-to-date, short consensus statement for healthcare providers. We know there are a lot of guidelines out there that are very comprehensive documents that have lots of references in them. They're usually 50 to 80 pages long, but they're not something you can practically use when you've got patients in front of you. So this is really meant to be as a guidance for what to do with the patient that you've got. And also, as part of that, we wanted to incorporate some of the new concepts from research related to two main areas. One is how to improve the calf muscle pump and the function of that calf muscle pump, and in particular, a lot of new work on what's called the muscle pump activator or neuromuscular electrical stimulation of the common peroneal nerve. And then the second part of it is an approach to advanced wound therapies, because there are lots of therapies out there, but the question is, which are the ones that really help you when you've got to, that sticking point? The other elements on this list are just the things that are involved or that are incorporated into that consensus statement, just the main topics that are there, and I will touch on some of those as we go through that. So the process of doing this, those leading it were myself, Dr. Gary Sibyl, Dr. Robin Evans, and Dr. Keith Harding. Many of those will be very familiar to all of you. And what we did was to bring together a group. In total, there were 19 providers from across Canada. We're looking at people from different disciplines, physicians, nurses, NSWOCs, therapists, and started out with an initial draft, which we circulated. We got feedback, we adjusted, we had a Zoom call to discuss relevant items that we felt needed more discussion. And then from there, we broke the consensus statement into sections and sent it round for consensus feedback. And what we're aiming, and we did 2 rounds of that, and what we're aiming for was to get at least 80% consensus on each of the sections within that document, which there are 23. And we're able to get 100% consensus on 20 of the sections, and in the remaining 3, we got greater than 85% consensus. So we're pretty happy with where we landed with this. And just to be clear, this was done independent of any input from any wound care companies. So I'm just going to touch on some of the new stuff that's in there. One of them, one area, as I said before, is how to improve calf muscle pump function, which is really the basic issue that we're treating with venous leg ulcers. It's the underlying cause of the problem in patients with venous leg ulcers, because then they don't have an adequate way of returning blood out of their leg. And it may be mostly because of previous DVTs, insufficiency in their deep or superficial veins. Sometimes it's more of a fixed ankle problem, but their pump doesn't work properly. And there's been a lot of development in terms of using the muscle pump activator, which you can see the device on the leg there, which otherwise known as the Gecko. It's the only one on the market. And evidence in people with who are normal volunteers, people with venous disease, and people with leg ulcers, demonstrating that it improves blood flow, arterial flow, venous flow. And this slide on the left shows the improvement in microcirculation with that device on. The graph that's there comes from the randomized controlled trial that Keith Harding and his team did, where they looked at the effect of adding the muscle pump activator to standard compression therapy in patients with venous disease or venous ulcers, just compared to compression therapy alone. And you'll see from that this significantly improved the rate of healing of those venous ulcers. So important new information that really is something that should help clinicians in terms of what to do with their patients. Then the other part of this is looking at the advanced wound therapies. I won't go into this slide in detail at this time, but we're basically ensuring that we looked at the elements of the wound bed preparation or the time algorithm, which would be familiar to most of you, I think. And then from there, it was, once you've got to this point and you're still not healing, how can you use the advanced wound therapies? And there are sequential steps. So this is meant to be a sequential process if things aren't improving. And at each step, you assess, analyze. If it's still not working, then you move to the next one. So as we got there, looking at bacteria and biofilm. Next step, looking at reducing protease activity. Next step, improving the wound bed. Next step, adding growth-promoting factors. Final step, adding cells. Lots of more detail behind this, but I won't go into that today. There's another talk tomorrow, which will touch on this perhaps in a little more detail. So what are the key components? So firstly, the description of what the diagnosis of venous leg ulcer involves. I won't go into that today. Many of you are familiar with that, but there's more detail in the document itself. And then the key is to treat the underlying problem, which is that impaired calf muscle pump function. And so the goal normally here is to look at optimal compression therapy, which in most cases is multi-layer compression, but there are other options available. And we use that assuming and knowing actually from assessing that patients have normal arterial blood flow. So looking at ankle brachial or toe brachial pressures. And then the other part is to encourage exercise. And where appropriate, in some patients, there may be a role at this stage for dealing with their venous problem if they have something that's suitable or amenable to a venous improvement. But in the real world, that's all fine, but we know there's a lot of patients that we treat who can't or won't wear compression, or they can tolerate some compression, but not, what we see as optimal compression. So the question is, what do we do with these patients? And here, what we look at in most instances is looking at one of the lower compression systems, again, of which there are a number of those available. The lower that ankle brachial pressure gets, the more caution that we have to apply, and certainly below 0.5, we really would not wanting to be putting on too much compression. But when we've got these patients, can't tolerate optimal compression, but we can get lower compression in place, we have now available the muscle pump activating device to add to that to improve compression. And then those that won't tolerate any compression, then again, we have that as an option with some form of, very mild bandaging or stockinette system. And then coming to the treatment of the venous leg ulcer, so this consensus statement incorporates the elements of time. And again, I won't spend much time on this. We'll touch on this a little bit more through the presentation with some examples. But basically, you work through those elements, essentially, dealing with the tissue, dealing with infection or contaminating bacteria, dealing with moisture, and then what do you do to help that edge to advance? The last point on this slide, though, is one that's really important, and that is that ulcers should be measured on a regular basis. And in most instances, if they're being seen frequently, we'd say do it weekly. If they're being seen less often, then do it at each visit. And then I'll go on to Amanda for the next section.
Okay, so case study number 1. So we're gonna, here's a typical gentleman. He's 75 years old. He's had his VLU for a couple of years, and he's come onto my caseload. There's an actual correction here. He was not wearing the 20 to 30 when he first came to see me. He was wearing a double layer TB grip. So when he first came to see me, he had a good ABI, biphasic pedal pulses. He had quite a bit of drainage coming from these legs, large serous, a little bit of bleeding when you're changing it. The peri-wound, very dry, scaly, thick scales to that peri-wound, hemosiderin staining where you can see that. And he had the lower leg edema, and this was him not wearing high compression. Sorry, that's a mistake. This was him wearing double layer TB grip at the time. And he was being followed by an infectious disease kind of in and off, on and off throughout kind of the process of him coming related to infections. So when we just finished kind of looking at the consensus statement, and so when we're going to just touch on this one, we're going to go through, are we going to hit, all the kind of the things that we need to with regards to this. So we'll start off with time, okay, and then we're going to walk down and see kind of more advanced therapies as we go through when we're dealing with hard to heal venous leg ulcers. So he's already been on our caseload on the system for a couple years. So we already know that we've tried lots of different things. Do we try everything and we're giving him everything to best practice? Well, no, we know that he wasn't getting multi-layer compression. So that was one of the things that we could look at doing. So we increased his compression, but we weren't getting very well with that as well. So we already heard the talk on hypochlorous acid. So that's part of my practice to do that. And we also looked at it, not just treating the wound. How many people go in there when you're looking at venous leg ulcers and you pull off the dressing and they have an area around the wound that's clean, and then the rest of the leg is like nasty, right? You got to think, and we talked about where all that bacteria comes from. That comes from the rest of the leg. And when these people are in wraps and they're not able to unwrap and shower before they see you, it's really important that you actually have that within your treatment. So now, and again, this was a long time ago. Now my treatment protocol is always about making sure that you write in your treatment protocol to wash the entire leg. Right? Wash the leg, wash the toes, because lots of our patients can't do that for themselves. So we're going to wash the whole entire leg. We're going to use advanced modalities. We are going to put in some collagen matrix. And then we're using Hydrofera Blue Ready Transfer we put on there. And this is the one I used. So if anyone's heard me talk in the recent, I typically under negative pressure will always use the classic. But this is what I had way back years and years ago. So I did use a transfer. One of the perks of this is it did allow me to leave that dressing on for considerably longer than just 3 to 4 days. So I was able to leave this on him for a much longer period of time. And then we applied the 2-layer short stretch compression system. So we're now got him into high compression. So basically I've like thrown all of my advanced wound care onto them. He's had it for so long to see whether we can't improve the actual outcome that we're getting. So when we take a look here, 1 week later, we have 34% healing in surface area. I'm thinking, whoa, we're going to heal this guy. This is good. We have decreased peri-wound edema, right? And most of that edema, when you look at it, was right around his ankle area. So he had the high compression wrapped, and he was using the Hydrofera Blue Ready Transfer. And that allowed us, again, for that 7-day wear time underneath his single-use negative pressure wound therapy. Okay, so again, he's on for a long time, the wound stalls, and now I'm not getting anywhere. I think I've used all my advanced things on him. Like, where do we go from here? So where would you go from here? Okay, what now? Do you have any suggestions on what you would do?
Yeah, so no, that's a really good question that you posed, Amanda. And I think this is really, where the consensus statement is really trying to provide you with that sort of guidance as to what you do. And, if you've done all the things that you believe are the appropriate things to do, then you do need to just step back a little bit and just to question whether you've got the diagnosis right. Because not everything that looks like a venous leg ulcer is a venous leg ulcer. Or sometimes they have other underlying problems as well. And one of the common ones I've seen in sort of my practice back in Australia was, 5% of the people we got referred to a leg ulcer clinic actually had an ulcerating skin cancer. You don't see it quite as much here, but you still see it. And so, you need to pause. And then other people have multiple diagnoses. So should you be doing something about one of the other problems that they have? Is there an underlying condition they've got that's actually impeding their healing that needs to be addressed? So going back and reviewing the diagnosis, and then if you're sure it's still a venous leg ulcer, then look at the compression system that you've got them into and make sure, are they actually using it, even though you're providing it and you put it on well, but they may be having it changed, comes back, I had to take it off, or yeah. So is that actually being adhered to for whatever reason? And just make sure, there is an infection, because it might have looked good the first time, but maybe something's happened in the meantime. And then if you're confident all of that's doing okay, then based on that study of Keith Harding's, then, this is an ideal opportunity to add something like the muscle pump activator to try and enhance that muscle pump. So make sure you've got that basic problem fixed.
Right.
And then, and I put in there considering, or we've put in there considering venous ablation again, if you hadn't done that before, because sometimes that's the little difference that helps. But then if you haven't, got all of that, if you've got all of that covered, then you'd start to look at, okay, so what can we do with some of these more advanced therapies? What things, can we work through, assessing each one of them at each step to see if it's effective? I'll hand back to you. Yeah.
So when I look back, because I've had him now for a long time, I'm thinking, okay, we actually did send him back to infectious disease. We did do a biopsy. Indeed, there was no cancer going on there. At times over the history with him, he did have deep tissue infection. He did have a pseudomonas, serious pseudomonas at times, was on long-term IV for that for a bit. We did put him on the calf muscle pump activator. And again, you get those healings that kind of go up and down, and you're just like, you think you're going to close and then you don't. So and as you're running through the gamut, so then what do we do? So we were stalled, we reassessed. So what did I do? I actually switched him, and you can kind of see with this gentleman, let's see if I can actually make this work. So So right up here, we actually saw that he had kind of a little bit of cliff going on there. So the margin of the wound was very, very firm. He had a lot of really thick skin that would develop up around there that we would have to kind of debride away. So I switched him over to the Hydrofera Blue Classic. And this actually, when you put this out onto the peri wound, I always say to put this on the peri wound about 1 centimeter out, and this to help try and flatten down those wound margins. And I get kind of excited. He comes back and I'm looking, I'm thinking, okay, I can see epithelial cells kind of coming in. So we can see those coming in on the edges on this side, not so much right up here, but definitely down here, you can see those coming in. So, and again, Hydrofera Blue Classic, don't get those all confused. So there's Hydrofera Blue Transfer, and Hydrofera Blue Classic is a different type of foam altogether. And this one actually would help, is typically the one I use under negative pressure wound therapy. And this one helps kind of flatten out those wound edges for you. It is non-cytotoxic and it kills bacteria and reduces bioburden. So we're addressing the tissue part. We're looking at the edge effect now that I'm trying to bring in, and we're trying to get moisture management in there as well. Okay, so 6 years later, this guy's coming in. We've tried to kind of transition him over the years into compression socks because we're not getting anywhere to give him a little bit more independence to be able to kind of remove that. But unfortunately, the compression sock in itself didn't control his edema. He had quite a bit of edema around the ankle. So now he's like 81 years old, okay? He still has a biphasic pedal pulse, but now he's complaining some discomfort around the ankle. Okay, if the wrap's done too tight. And then he was also kind of complaining of pain up the leg by the wrap there. The drainage is still pretty high considering, where it is, and that he doesn't have a necrotic wound bed anymore. And again, continues with that thick hyperkeratosis around that wound. And he still has that lower leg edema, even despite using kind of the high compression. We can keep it under control. When we don't keep it under control, his wound blows up. So now what are we thinking about? We need to kind of keep the debridement going down. We can talk about here, we're looking at the tissue part here. So on an ongoing basis, debriding a wound. And he can take quite a long time because that tissue is very, very hard. You have the scalpel going on, and we'll talk about some of that going forward. So when we're looking at the consensus statement, going back to this gentleman again, we've looked and we've talked about kind of going through him and making sure that we're meeting all his needs, right? So what are his needs when we're actually looking at this? So the debridement part, if anybody, we talk about new products coming out and kind of getting excited. This is one of the products. I mean, how many people actually feel really super comfortable doing sharp debridement and have the time and energy and can do it, let's say, every week? Every week, every 2 weeks, every 3. You're lucky if you get out once a month. You're doing virtual, right? So when we're talking about that, right, and you're actually, that this person needs debridement, and you can't do this on an ongoing basis, what we know needs to happen, you got to think about other ways to safely debride. So I encourage you, this is kind of like one of my favorite little products to have, and the Cutimed DebriClean is, and I know we talked about in the earlier talk today, when we looked at actually kind of, they were talking about scrubbing the wound. Christine was talking about, getting it and scrubbing the wound. Well, this is a really nice product to actually scrub your wound with. So it really does clean it up quite nicely. So I suggest you all kind of take a look at this. It is one of my things. And I will now tell the nurses that they could do that. Okay. So this is something that a nurse can do. They don't have to pick up a scalpel to do this. Okay. So going forward, we're looking at preventing this gentleman from getting infection. So how can we prevent him from getting infection? And this is where we get into using a non-cytotoxic antimicrobial. So no bacteria resistance. This guy's been on them for a very long time. We want a cost-effective, something that he's not going to develop resistance to, no risk of allergies. We know that people with venous leg ulcers get lots of allergies, and no cytotoxicity. So this is the one that we went with, okay? This is Cutimed Sorbact. How many people are from Ontario? Guess what's on your formulary? Okay, so how many people have used this in the past? Not too many. So this is a new product for most people. So I really encourage you to go over to the booth and kind of learn more about it. And we're going to talk a little bit about it today on actually how it works. So Sorbact, mechanism action. I'm going to give you the really simple version of it. It actually is kind of like, it goes down and it sticks to the bacteria, and basically you pull it off and you're pulling your bacteria off with it. And then we're going to give you the more scientific.
Yeah, so it's not much more complicated than that. I mean, basically, what the bacteria adhere to is a fatty acid. So they're hydrophobic fatty acids in this dressing product, which adhere to the cell membranes of the bacteria. And so when you take the product off, they're attached to it. So it actually works in that way. I've got another question for you, Amanda. In one of your earlier slides, you talked about, using hypochlorous acid, and we had a talk about that earlier in the day. How do you use hypochlorous acid, for wound cleansing?
Yeah, so that is part of my standard kind of protocol using that now. So I would do a soak with it. I always kind of say on my notes 5 to 10. Like if you get in that ballpark, I'm happy. If I'm doing debridement, if the wound is pretty dry when I start, I'll do a soak prior to starting my debridement. If I do debridement and I'm doing an aggressive debridement, then I will definitely do a soak following that. But typically 5 to 10 is what my kind of general guidelines is. And I actually now also say, don't just do a soak on the wound. Again, I will say do a soak on your peri wound. And I really encourage you, if you are a person who is writing those consult notes, to make sure that you write that consult note out. Do the soak on the peri wound. If those people, I know we have a lot of people in the community, and I will often tell people, because I know our nurses are stressed and they're trying to get in and out really fast. And I will tell the patients, take down your dressing if they can, and slap on your soak. Okay, just slap on the soak. When the nurse says, hey, I'm on my way, just take it down, slap on the soak. That way you're going to get better results.
And so that's a non-cytotoxic chemical, and this also is a non-cytotoxic dressing. So
and for those patients that we're using long-term, right, these are kind of things that you want to keep in the back of your mind, right? Using something that's non-cytotoxic for our patients, something that they're not going to develop resistance to. So now we've addressed kind of one of the things we want to look at now is moisture management in that time paradigm. So when you're looking at moisture management, I'm looking at now, this guy's got this wound, right? He's 81 years old. He's not able to take off the wraps independently. So he has to keep them on all the time. I'm like, how am I going to make it so that he can actually shower and be a little bit more independent? He's got a lot of drainage. So they were using, the Mesorb pad on everything because he couldn't use the foam because it wasn't absorbent enough anytime I used that, or you'd have to come in too often for it. So Cutimed Sorbion Border, this actually allowed me to put this on to the gentleman, and then we transitioned him into a wrap, and you'll see that later. But now he could actually take off his wrap that we'll talk to you about in a bit, and be able to shower. So I think we kind of went over that part. So when we're looking at the optimum multi-layer bandage, right? So I transitioned him into the Ferro Wrap 4000 series, and there's a bunch of different ones in the Ferro Wraps. The 4000 series, I really like it. It's pretty simple to use. It doesn't for patients to use independently. So this was something that he was able to now use independently, so he can take it off, he can have a shower, and he can put it back on. And at night too, because he was experiencing some discomfort now, although his ABIs and stuff were still okay, he was still experiencing some discomfort, especially if somebody put that wrap on a little too snug. Now this gives him control, right? So now he can ease it off if he needs to. He can take that wrap off and just leave the compression sock on when he's sleeping at night. So this gives him some independence and some comfort, and we're addressing the patient-centered concerns. What can I do for my patient? Not just, the wound part, but what is his concerns with this?
I mean, one of the things with the compression systems is there are different types of compression systems, and you'll see a lot about elastic and inelastic compression systems, and they both have advantages and disadvantages. But Some of the short stretch, which are often referred to as inelastic systems, are ones that some patients find more comfortable because they don't have as much compression when they're just at rest, whereas it does give the support when they're exercising. And so sometimes there is advantage in going from an elasticated multi-layer system or an elasticated stocking to something that's a short stretch system that some patients find more comfortable. And similarly with the wraps, I mean, they are more of a short stretch type system. And here patients can adjust them so they don't come back with their dressings completely off,
Right.
or down to their ankles. They've loosened them. Hopefully they've tightened them up again, but at least they're still on.
You know, and I heard a question earlier, someone about, you know, what do you do to get patients, you know, into their compression system? Giving them a sense of control, right? So giving your patients a sense of control when it comes to the compression is really important. So when you slap on high compression on somebody and then it goes wrong and they don't want it on there and then they have to take it off or something like that, that's not really a sense, because then you get that yo-yo effect. They take it off and you come back in, their legs all blown up again. So where do you go from there? Then you put it back on. So I think giving your patients a sense of control. So if you're in the 2-layer compression wrap and they need to take it off, then have a backup system for them, okay? If you have to take it off, then this is what you're going to put on in the meantime. So maybe you're using the, you know, the tubular type of system. Maybe you're using like the edema wear type of system, put this on, or maybe you just tell them to put on a very low compression sock. So you have to make sure that you're working with your patients in order to address the underlying cause of their issues. So I think, and I'm really excited that we actually see this on our these compression types of wraps on our formularies, that it'll give them a sense of control and that we can actually more cost effectively manage our patients. And this just goes to show you that when you think about it, anytime you can reuse something and you're reusing your wraps, it's going to be a massive cost savings. When you're talking about how much money we actually have spent on putting somebody in the compression wraps for, you know, years, and these patients with VLUs, I'm not sure the statistics, how long they typically have a VLU off the top of my head, but sometimes patients years and years, and we can see this one. So the amount of money that we can save by using your Velcro compression wraps is huge. Okay, so I think when we look back at the consensus statement, although this is about VLUs and managing VLUs, VLUs aren't a purist thing. We know that VLUs lots of times have other underlying causes and issues that kind of get grouped in with those. So this lady comes in to see me, and she has been a long-term patient as mine as well. She's had these wounds greater than 10 years, multiple disease processes in play, pyoderma being one of them, vasculitis. Over the time, she's developed a fixed ankle. And I always look back and go, oh gosh, is there something I could have done to prevent that fixed ankle thing happening? And she, you know, she's up and walking. She's not old. She's only like, definitely not old. She's only my age. And so I always wonder, like, going back, you know, can I learn from these mistakes? So we were having that conversation earlier as to whether you can actually, you know, prevent that from happening. And I think part of the issue is that, you know, when you have serious wounds like this, and she's up and walking around, but making sure that maybe we got physio involved and that we actually did those ankle movements, because walking on your toes, obviously long-term can cause some issues. And that's probably kind of what happened when she gets in painful periods. She doesn't actually get that flex in the ankle. So now we're looking at somebody who's got high drainage, ongoing risk of infection. This is her biggest problem. I think, oh my gosh, we're going to get you healed. This is looking amazing. And then all of a sudden, boom, she blows up an infection. And it's so frustrating because she goes to her family doc, and I call the family doc and I'm like, I need antibiotics for her. And the doctor's like, oh, you know, you need to come in to see me, and won't give them. And, you know, by the time she's been living this for so many years. Think about if someone said, you know, just stop work again, just come on in, just make an appointment in a couple weeks or a couple days so that we can give you antibiotics. And so she would blow up again. So it's really important for her to make sure that we don't get her infected and that we use an atraumatic dressing for her. Because if anybody knows what pyoderma is, you don't want trauma to the leg. So often, you know, she's working, she says, oh, I banged my leg on a shopping cart. and then boom, it's like blows up again. So we really want to make sure that we're addressing our patient-centered concerns with these chronic long-term, I say VLUs, but there's also a lot of other things going on here. Cutimed Sorbact, again, atraumatic, easy to use. You don't have to cut it to fit, okay? Just put it on there. It's not going to stick. We're going to address the infection part with that, preventing infection. And the Cutimed Sorbion Satchel, extra large. This product was a game changer for her because one of the big things that she was complaining about is, can you imagine going to work and your leg starting to leak and it's like dripping down your leg and it starts to smell? And then we had to put her in double layer compression, high compression. So we had her in high compression. Now the wrap is smelling, it's wet, it's in her shoe, and she's at work. So these were her concerns. These were her concerns. I'm thinking, okay, how can we manage this? So when they asked me to, hey, can you trial this part? I'm thinking, it's one of those diaper type of dressings, and the problem with those is that they clump up. And it's a diaper technology, and they all kind of clump up, and it gets very uncomfortable and very heavy. So I encourage you to kind of take a look at this one. This one's got it still has that diaper technology, but it's got the fiber in it that doesn't allow it to clump up and slide down. And if it breaks, it doesn't send beads everywhere. And then we transitioned her into the Velcro compression system. And this lady actually does all her own dressings. So it's important that she has the ease of access. So one of the big things too is that she would get sometimes tired of doing her dressing. You know how long it takes to take down your dressing, do the dressing, put it back on, put the double layer of compression on. So sometimes she would just get fed up and not do it. So this way it's much easier for her to manage. So she was super happy about this part. And she says now she can put her shoes on with, I know a lot of them say, oh, it's nice and slim, you can put your shoe on. Yeah, not all the time. I'm not sure who wears big shoes, but you can't always put your normal shoe on. So I already talked about kind of the compression about the Cutimed, and they also had that same type of product in a silicone foam, okay? So case study 3. So this is an interesting one. So this is a 77-year young male. He has a right ankle venous ulcer since 2021. We did get him closed. So we did get him closed even using lots of our advanced therapies, but he closed and then he reopened. And some of these cases, they're just going to be chronic. You close them, they reopen, they close them, reopen. And you think, is there something that we're missing here? Is there something that I could do differently? And I think now going back when I started, I think we sometimes get stuck in a rut. And I think going back when we started and what we do changes over time as well. So vascular, I've sent them to vascular in the past, but typically I have to say historically, way back when I started, vascular was like arterial disease, right? You sent your patients when they had arterial disease. Venous, you treat with compression, right? So that was kind of stuck in my head, but I think I would now be more friendly to my vascular surgeon, and because there are options there. And we're going to talk a little bit about that. So this gentleman comes in, relevant previous medical history, hypertension, atrial fibrillation, dyslipidemia, coronary artery disease, but he had actually good ABIs. So then he came back in, he came back on. We did transition him back into a compression sock. We did again go through that whole kind of advanced modality thing. We did use the muscle pump activator on him and we got him to close, but then he kind of reopened. Now we sent him back and to vascular, and he did come back in right after he had it and said, my toe is a little sore. And he says, I actually just went to the vascular lab as well, and they told me my whole arterial system was all really good right up until the top of the foot. And he says he has a blockage right on the top of the foot. So I'm waiting for the vascular consults.
So you throw me the tough one. So I think, with this patient, probably two things to think of. So this patient obviously has been able to heal their wound and they come back. And what we have to always appreciate is over time, our patients change as well. And so while a patient might have had a good arterial or even venous system, and you've been treating this patient for Was it 10 years plus?
No, this one's about three,
Oh, well.
yeah, three years.
And even in that sort of time frame, things can change. So what was good a few years ago may not be good anymore. So absolutely, in this sort of situation, the key thing is to look at when it's not improving, just evaluate things, and part of that is to do a proper evaluation of both their arterial and the venous system. Because even treating venous disease has changed a lot in the last 10 years, and there are less invasive ways of treating incompetence in the venous system. And there's better ways of treating more distal disease in the arteries with angioplasty. So definitely reassessing and seeing if there's something that can be addressed from a vascular standpoint is absolutely the right thing to do at this time.
So I just had a thought. So nitro patch, what are your thoughts of using, because I do use this quite often, normally 0.4 milligram cut in half, just above the wound, on for 12 hours, off for 12 hours. How many people use nitro patches above wounds, just above arterial wounds? Nobody. I do it. I learned it from Dr. Civil, if that means anything. But I actually do, because it kind of opens up.
Yeah, I can make a brief comment. I mean, that's one option you have for sure, and it does dilate some of the vessels locally, so it can improve the circulation locally. The other thing, interestingly, that helps this, particularly in people if they've got arterial disease that you can't reconstruct, is actually going back to the muscle pump activating device, because there's good evidence that it actually improves arterial flow as well as venous flow. And we're starting to use that now for some patients who are not reconstructible with vascular surgery. So I know you've already used this on this patient, but
I tried to get it again.
Yeah.
It went off formulary.
Oh, well, there we go.
But yeah, I actually did try to get it back again for him, because we did have really good success with it. So again, when we look at the actual, the steps that you're walking through when we're doing this, it's really important that it's not a straight down, you hit the bottom, you're done. Sometimes it's halfway down, back to the top, all the way down, back to the top. And for me, and I know that anybody who's got a really busy practice, sometimes when patients come in, we forget to sit back and go, you know what, am I missing the boat, right? Instead of thinking about, okay, what else can I try dressing wise? What else can we do? You need to think, am I addressing the underlying causes really significantly enough? So making sure that you jump back up to that top and reassess the whole entire kind of picture. So again, you can see here, and he was definitely one patient that would take me quite a long time to use to debride him, because the tissue was quite thick. But I did use the debris clean on him, and I did switch him down to a lower compression. So he's used different types of compression over the time. We did have him in compression socks. He wasn't doing too well. He said he was getting swelling with those, so he went back to the actual 2-layer wrap. Again, I have him doing his own compression, and you can see here he's actually wrapped in the 2-layer wrap. And their 2-layer wrap is called the Compre 2, and so we switched him down to the Compre 2 Lite.
Yeah, so this just comes back to what we talked about before. If people aren't able to wear compression bandages, you've got a bunch of options with different types of compression, as Amanda's talked to, the lower level compression, the short stretch compression, the Velcro wraps. So those you can adjust. But if you're having to do that, so you're not really giving the optimal treatment for the calf muscle pump function, then this is where you can improve that further with the muscle pump activating device. So this is where it really does actually add to what you can do for that patient. And then, of course, if they can only tolerate stockinette, then again, you can still use it there as well. So,
how many people write in and actually tell their patients to elevate their legs above their heart? Elevate their legs above their heart, okay? I typically say, 40 minutes or so, maybe a couple times a day. If you can do that, that's great. How many people say walk a lot? Yeah, not many. And you know what? It's one of those things now that I will actually make sure I tell my patients, but I'll write it down, because I know that all our nurses, when I say, they'll make sure they say, you know, elevate your leg. You get swelling, elevate your leg. You get the mixed disease, and then patients get really confused because somebody says, put your leg down because it will feel better. And then the next nurse says, no, elevate your leg. And that's that up and down motion, right? But one of the big things that we must tell our patients is to make sure that they walk a lot. Standing, not so good. Sitting, not good, but definitely walking. And that, going back to the calf muscle pump, when you look at that one, that actually increases your blood flow similar to walking. And that's why I'm thinking, okay, you got to make sure that you tell your patients to walk, right? And I think we take that for granted. We tell them, you know, if it's painful, don't walk or whatever, but definitely to make sure that they're walking with regards to that. Okay, and we already talked about that one, so we did reduce them into a lower. So here's our final case. So this lady had a long history of VLU that was untreated. So when you have untreated VLU, typically then you end up with damage to your lymph system. So now she has lymphedema as well. So you take a look. So she was a patient of mine way back. We did actually transition her into a Pharaoh wrap. She didn't typically wear it a lot, and I think that was because kind of the staff sometimes were like, I don't know how to apply it. But she banged her leg. And what is the first thing everybody does when they bang their leg? Even if they're wearing compression, the first thing they do is they take off their compression. You're like, no, you bang your leg, get that compression on, and don't take it off. And probably if she had that compression on, she wouldn't have left with such a massive hematoma. But so now she's got this massive hematoma. So I go in there, look, it's pretty fresh at this point. And we look at it's very painful. She has inflammation developing to the lateral side of the leg, and it's moving up into the groin too. I'm not sure if you can see it with these pictures, but through here she was quite red and hot. And then there was redness coming up through her leg here. And this is, although this is like a hematoma, it's pretty soft at this point, right? So it's not like a hard eschar, it's pretty soft. So what would you do?
Yeah. So ideally, if you had the resources and the appropriately trained people available, this really should be debrided. All of that black tissue with the hematoma underneath needs to be removed, because the biggest risk of that is infection, and you're already starting to see some of that. So you get it down to tissue that's not devitalized, so get it down to tissue that's
Would you debride it right now?
If you could get that person, the sooner you can debride that, the better the quicker it'll actually improve. So if I had an open operating room tomorrow, I'd take her in and debride it.
Okay, so,
But
my
most people
operating
don't
room
have
was
that
full
access.
because my last patient was still in there. She was taking forever to get out. So this is actually long-term care. So when you go in and she's got the actual infection going, and it's not like a hard eschar, so it's that soft part, and it's pretty fresh. My concern is like, you know, is she still actively bleeding, right? So that's my biggest concern, is she stopped bleeding? Have you like decreased or stopped her blood thinners? And then to treat the infection first. So being a little bit more conservative. And then I said, you know, and then get her to a doc. You need this, you know, if you can get this surgically debrided, that's going to be way quicker, because unfortunately, again, I can't see her, you know, once a week or every other week, like once a month is what I get in to see her. So we did start her on antibiotics, got the antibiotics. I did say get into the referral. So this is what happened. We actually talked about this already. So I came back and we look at the time. So what are we going to do at that point? We're going to treat the infection. Moisture, it's dry skin, it's intact skin at this point. You can see that there's not much drainage at all. So they had just put some Inidine on it at the time, and that's fine. It's not doing anything at the time, and the skin's still intact. Okay, so 1 month later, I go back in to see her. She didn't get in to see. She couldn't get any surgeon to take her. Okay, so nobody wanted her. And vascular was full, so he didn't take her. So where do we go from here? So now the infection's under control. So I didn't see any like outward signs of infection. I no longer feel that she's going to bleed out on me. And I can see this is still really black, firm, adherent eschar. right? So, everybody says, how many people debride black, firm, adherent eschar on the leg? Everybody's like, no, leave it alone. But really, you can't leave this alone for this lady. Despite her being like 92 years old, she's sharper than a tack and wanted this off. So we look at it, and I didn't start taking the picture till actually I just started. It was fully adherent. So I agree with Dr. Stacy. So we needed to kind of get rid of this. So I started kind of chipping away here to see kind of what am I dealing with underneath there. This actually, I needed much bigger tools, right? So a scalpel, it's like trying to cut like the top of the thing. It doesn't really cut through. So you break out your iris, sterile scissors, and you're trying to you're basically like chipping away at it. And it takes a long time. So we chipped away at it. So I chipped away at it here, and you can see that I've kind of taken a good chunk off the eschar part off up here. And it's quite deep, and I was swabbing all that stuff out there. Now this part is still very adherent to the skin. So time-wise and stuff, this takes a long time. So we kind of stopped there, and then I told them to kind of get up under there and kind of keep swabbing that out, doing my hypochlorous soaks, and getting them to be aggressive with their cleaning as much as possible. And then, yay, 6 weeks into treatment, eschar is all gone. Okay, so what do we do now? We have a big wound on her leg. This is a big wound. It's draining a lot. And she screams bloody murder when the nurses come around to do it. And the nurses are telling me, you know what, it takes well over an hour because she's so, particular and wants everything done her way. So how are we going to address this? So Hydroferro Blue Classic to the wound bed, overlapping onto the peri wound, again, about a centimeter or so. We did use the Cutimed Sorbion Satchel extra large for drainage wise for her. Okay, so that they don't have to do those drainages, those dressing changes very often. And then we transitioned her. I tried to get her back into her compression. So she was saying it was way too painful for her wrap. So again, I'm like, just start with a single layer of TV grip. Just keep trying to ramp it up as much as you can tolerate. And if you can only tolerate it, during the day a little bit, and you have to take it off, then fine. But you have to start with something and then tell me you can't, and then take it off. That's why I always say, start with it. If you don't tolerate it, then here, take it off, and this is your backup. Okay, so the drainage is now way down. We have a nice clean wound bed here. We can see that it's doing really well. And we can see new epithelial tissue coming in. But now we have the problem with the wound isn't draining that much anymore, okay? And we are using super absorbents on here. So now what are we gonna do when it's kind of drying out? There's multiple options you can do. But what we did do is we switched her to the Hydroferro Blue Transfer. So this type of foam does not dry out. You don't wet it first. And again, so we switched her to the Hydroferro Blue Transfer with the super absorbent, and then we switched her back into her compression. So you can see her ferro wrap here. This ferro wrap is about, I want to say it's a few years old at least. I think it was around 5 years old. She hated wearing the foot piece, so I made her put the foot piece on just for the picture. You can see the foot piece is all nice and clean. The rest of the wrap isn't. But this is how we kind of managed her going forward.
Now that Amanda's done all that and has finally healed all these wounds, as she's the guru of doing that, the real challenge then is how to stop these coming back, because we know that venous leg ulcers have a high rate of recurrence. And so here, compression is really the key goal to that prevention. In most cases, we're looking at below-knee compression stockings, but there are other options that we have available to us. And you can see here some of the options with compression stockings. Using that ferro wrap is still a good option at this stage for some patients because they can tolerate it. You have higher and lower level compression stockings, and what's really important that you find out what the patient will wear or is able to wear and encourage them to keep wearing that. And what you don't want is to try a high level compression. They just say no and then they wear nothing. I think, at the end of the day, it's whatever compression they can tolerate is the best we can do for them, and that's what we want to do. But we really don't want these people to go without any compression because they have a much higher rate of recurrence.
I think that, and when you're looking at compression, I mean, How many people just find, putting on high compression on a big leg is an easy job? Like, it's definitely not an easy job, and patients say they can't do it. And a lot of our elderly patients can't do it on their own. So then you got to think about what you can do. What can you do? There's aids, there's putting on sock aids and stuff like that. It's still a pain in the butt. So if they are willing and able, I always now transition my patients into using the Velcro kind of type of ferro wrap system, because this is way easier to put on. It's quicker to put on. And when it's easy and quick and comfortable, they're much more likely to use it. So just keep that in mind as to an option. And to boot, I will often do multiple things. You know what? Some days you can use your ferro wrap, other days you can use your sock. So giving them some options, right, of how to do that. Okay.
So this is just, if you want to get a copy of the consensus statement, there's a website there for it, and the QR code, if you copy that, it'll take you to the website and you can download a copy of that consensus statement. So while we're waiting for people to get up, I'll just, a couple of questions. One of the questions is it true that when you put the Cutimed Sylbion under compression, it reduces the compression when the Sylbion is saturated?
So I think when you're looking at multi-layer compression, like the more bulk can decrease the amount of compression you're getting, but not really. Right?
It shouldn't really reduce it.
No.
Okay, we've got a question in the room.
It was just when you use a ferro wrap and starting at the ankle, is there anything you've got to be cautious at times you can't use it when it's just starting at the ankle going up, when you don't have it on the foot?
Oh, so if you don't have the ferro wrap on the foot?
That's right.
Yeah, so a lot of my patients don't want it on the foot. They don't want the actual ferro wrap part on the foot or the compression part, because it is kind of the Velcro part is bulky. So often I will just put on like it comes with an underlayer sock that has compression to the foot part. So you can definitely get away with that. Now, you have to read your patient. Some patients get a lot of edema in the foot and others don't get that much edema in the foot. So I think it's just about making sure that you read that and making sure you're addressing that. Sometimes I will give them, they'll put on just like a compression sock on the foot and or a tubey grip type of thing onto the foot and just continue with the ferro wrap from the ankle on up. I mean, obviously the one that comes with it is a compression part to the foot as well. Like a compression, you have the option of the compression sock on the foot and the compression Velcro wrap on the foot.
Okay, another question. Is the ferro wrap 4000 used in place of 2-layer compression wrap?
Yes. So the 4000, it is high compression all on its own. So you don't need to use the 2-layer compression wrap in conjunction with it. That's all on its own, the compression. And one of the nice things is, although it can be high compression, you can adjust it and make it less. And that's one of the nice things that when you're, a lot of times the patients go, my leg, I was wearing compression socks and then I stopped and then my leg swelled up and now I can't get my compression sock back on. So one of the nice things about that is if people aren't super compliant and they, go to the beach one day and don't wear any compression, you can still get that wrap back on and then get your leg swelling back down. So often those long-term patients, I will tell them to have both, because that will get their swelling back down. And even if they are compression sock wearers, it gives them that flexibility.
So Amanda, here's one that you might enjoy. I'm not sure what they're referencing, but you could reference it to almost any of the products we talked about. It says, how does this compare to old school saline soaked wet to dry gauze dressings? Yeah, I thought I'd get that response.
So how does what? Any advanced treatment? I mean, we're talking about wet to dry gauze. I'm not even sure I can respond to that. So basically now people are saying, I heard the last one, saline is like a no-go. But when you're talking about wet to dry, that's mechanical debridement, right? So again, it can be a good way to mechanically debride a wound, as long as you're not looking at, if you debride healthy tissue and necrotic tissue. But if it's all necrotic wound, it'll definitely debride your necrotic wound by sticking to it. But then it requires, daily dressing changes. I don't know. It's.
And I think, adding to that, I mean, one is the pain that comes with taking those things off. And the second one is you're removing healthy tissue when you're taking that off as well. And by allowing the wound to dry out, we all know that what happens is you actually destroy tissue by doing that too. So it's not really the approach anymore. It's ancient history as far as I'm concerned.
Yeah.
Although occasionally I hear some of my residents talk about it, but I quickly correct
beat them down over that. Yeah, I mean, I think that's one of the biggest things that we do as nurses. And I know that we talked, there was a talk earlier today about that, is about not changing our dressing so often. It's not about just like the cost and everything else. It's also about actually the M part of time, moisture management. Every time you take off a dressing, half the time you're putting back on that dry dressing, right? And then that wound is dry. I often found that our nurses are keeping our wounds much too dry. We have a question here?
No, not a question. I'm Bonnie, one of the clinicals with Essity.
Right. Can't see you in there in the lights.
Oh, you can't see me? I just wanted to address the first question. Sorry, there's an echo. I'll stand back. There is the clinical data that we have with the Sorbion for both free swell and under compression for the Sorbion. So if anybody wants a link to that data, they can come to the booth. It's pain cut and cutting that you can find it yourself online, but come to the booth and we'll provide that for you. Just to let you know. Okay.
I think we're
good.
Run to the end of our time. So there are a couple more questions, but we'll have to hold those, I think.
Yeah, I hear that the booths are now open, I think.
Correct. Yep.
Well, thank you very much for all staying.
Yep. And